Hello, Ömer. Can you hear me? This is Bektaş.
Hi, hello Bektaş. Yeah, I can hear you very well. Can you hear us and can you see us?
Yes, I can see and hear you very well. It's really a pleasure to have you here, and it's an honor for us.
Thank you.
And yeah,
Yeah.
can you please introduce the case?
So yes, thank you very much, Bektaş, for inviting us your CTO and chip meeting, Iran CTO and chip meeting, second edition, I believe, this year. Unfortunately, I can't be here, but next year I'm really happy to be there physically, if it is possible. So yes, we have a CX CTO case for you, and Haşim, my co-worker, will present you in a second. But before that, I would like to introduce co-operator who is Şeref Kul. He is head of one university department in Istanbul. So, can I ask Haşim, could you please present the case for us?
Thank you. Thank you for Dr. Bektaş Beyani, and good morning. Our case, 41-year-old male with chest pain on exertion. He has hypertension, and echo shows normal EF and no valvular disease. The coronary angiogram was performed 1 month ago, another center. CX body totally occluded and failed CTO attempt for CX. Patient referred for PCI of the CX CTO and RCA revascularization. This is the images, and the images show the LCX body is totally occluded and filled ipsilateral. We have some collateral from RCA as well. This is there are another view. There are some disease parts on the in the LAD, but non-significant. And here the RCA, as you see, we have some disease part. We will treat RCA as well, and some collateral to CX, distal from distal RCA. And here unsuccessful attempt for CX, just single access, and like the not stiff wire, and the unsuccessful about one month ago. And these are the last images. And thank you.
Okay, so you have seen the case. Before you discuss, let me show you what we have this morning. This is RCA. We have some feeling from RCA, and we have disease part at the mid RCA, which will be treated by this DCB after CX procedure. And next, please. And also we have left image from spider view. We have, properly have all views, because if anything happens, we have to compare, before the procedure and during the procedure, we might have something. So we need to have reference pictures. So we had proper images. So it is epicaudal, and after OM, it's occluded, and attempt case, I would say at least. And distal CX is huge, very good CX artery, patient is young. And there is feeling from ipsilateral. We will work on it now, but let me show you first all images. This is right caudal. Again, we have feeling. If you look here, CX is filling distal, from distal to proximal, right? So it shows me sometimes CTO fills some part from antegrade, some part from retrograde. But I think here, purely CX filling from the retrograde, because the first part, filled part is distal, very distal, which comes diagonal. I will show you that one. And there is nothing actually anti-greatly. There is no, I think, good channel anti-greatly. This is not show that much, but I like to see LAD. And here, and after that, in here, for example, I'll try to show you connection, because when we try to find where is the connection, there are lots of branches here, as you see. Let's work on it, and please stop at the beginning. Okay, now come back. So yeah, okay, we have to go frame by frame slowly, please, and then we will stop at the first image that CX started to fill. Now nothing. Next, yes. Now come back. Now I see something. You see that the distal now fills, right? So distal is fills, and then I don't know if you could see it in your screen, but it's very obvious to me in the lab. One of the diagonal branch, very tortuous one, but supplies CX. So that's the source of the collateral, I think. The whole story starts from here, and then it goes distally. I don't know, there could be another collateral from somewhere, but I can tell you definitely there is a connection. Very tortuous, of course, it's epicardial, but feels from diagonal. Next, we have another collateral from RCA, right? So in here, so you see that in this bilateral injection, dual injection, timing is not good. Did you see it? First right injection done, and the left injection. But the thing is, we should know that both there is supplies from both arteries, so left and right supplies CX. So both of them supplies by collateral. So in that case, I think we had better inject two guiding in the more or less same time to have nice image, because here we inject right, we have something, but we were late for the left, so it wasn't good. Next, so we try to do better timing, which is we now inject together, and we have better actually feeling. And here, do you see the collateral from right, guys? We have a good collateral from right. Here, maybe you are not clear, but if we do only right, next please, and frame by frame, next. Here, you see it?
Yes.
Yeah. We are working by radial approach. We have right Judkins for 7 French right Judkins for right. And of course, we send a wire for protection. And we have left EBU 3.5, 7 French from right.
If integrated approach fail, which retrograde approach and which collateral will be your second choice? Would you go from RCA or you will choose the epicardial ipsilateral collaterals?
Yes, I think I would go with the RCA. It seems to be more straight.
I think so.
Yes. So yeah, that would be my next choice. Hopefully, but I will do my best to recognize this CTO antegrade, because retrograde is yes doable, but we may fail to cross both collaterals. So I think we have to take a good chance for antegrade. Yeah. What do you think?
I think so. Yeah.
Yeah. There is.
And
there is no.
What's your first choice? First wire you choose for this lesion, Ömer?
Okay, very good question again. I choose Gaia second. The reason is why I didn't choose hydrophilic wire here, like Gladius EX or Pilot or Fielders XT, because we have side branches, small side branches, and hydrophilic wire could go easily one of them, right? So, and I need to direct my wire. That's to puncture the proximal cap. So Gaia series are very deflectable wire. So Gaia is my first choice here. Second. Because why I didn't choose third, I don't know. the stiffness of the lesion. So, you know, Gaia 30 is always, of course, more stiff and then easily can go distally, but sometimes goes easily outside the vessel. So, and now I push more to side branch a little bit and pull back all the system because I don't want to lose my position of, because the proximal, we don't have that much landing zone for proximal, so I pull a little bit back. And also I think it's good not to use microcatheter here like with nose, I would say, like Corsair or Turnpike, because they have a long nose and then they can easily prolapse, you know. When you try to pull a little back your wire, it could more easily prolapse to LAD because it's proximal. There is not that much landing zone, I think. Anyway, so as I suggested, I like to go spider view to direct my wire first, and this penetration is extremely important. And I don't think I have a good chance for IOS here because of the side branch is very small. So, okay, let's see from yeah. Let's see first injection, please.
Antegrat.
Ya tabii. Antegrat. Burayı punction yaptıktan sonra antegrat. I can go a little bit more distal. Test. It goes somewhere. Okay. This is, yeah. I don't think this is.
This is not in the lumen, yeah. I think.
No, it goes side branch.
Yeah, maybe.
Kaydet. It's okay. I think that's side branch. Yeah, I have to go a little bit more distal.
I think it's better to use a workhorse wire
up to there.
Reach.
I agree with you. Yeah, I mean, I agree with you. Yeah, it seems more difficult than it seems. Yeah, I agree with you. I would use workhorse wire to end that part. Yeah, but anyhow, I think I managed to find that lumen, right? So, but that's good suggestion for sure. Okay, injection please to see where should I go. No, test please. Sine.
Yeah, good direction, yeah.
I think I have to go directly distal, right? So CX has curve there because it's around the mitral valve. We don't see it AP view, right? AP view it looks straight.
Yeah.
Anyway, I don't know where is it going. It went somewhere, and you know, I didn't appreciate that I went too far from spider view. You see, I just send the wire, but yeah, go from yeah. Good injection.
I think it's in a good yeah, but you should pull it back and redirect it to the.
Yeah, I hope it's in the lumen. I don't know.
Yeah.
Let me see. And I'm surprised why it goes that small branch. We have a big branch there, so I think I'm 71. Again, I think. Oh no, I think fine. No. Because after contrast, it went a little bit. You see that? At the end, contrast could push that. I like it.
Yeah, very good.
I think
perfect.
So. Yeah.
Perfect. Yeah.
Yeah. So I think we crossed it greatly, and I'm sorry for you guys, for the audience. I'm sure that you would like to see how we struggle from the retrograde.
So Ömer, you will leave us with lots of free time.
I can give you another transfer if you like. I have an instant CTO&CHIP CTO if you like. No, I'm joking. But we have the case. If you have free time, let us know. So. My microcatheter, why did you ask did I tell you that I'm using M3, fine cross M3 Niv Microcatheter of Terumo.
Balon
Şeyi
aldık
kullanabilecek miyiz? Ha.
Balon aldık mı? Trap. Trap.
Trap balon. Let's do Nanto. Let's try to Nanto technique here. It wasn't that difficult to cross. If it is very difficult, we never do Nanto. We don't have any small risk. İçine girdi mi abi? Ben göremedim tam.
Evet,
22-24. Tamam. Yeah. So,
Ömer,
2,5 balon.
it was not an easy case, but in your hands you made it easy.
I don't know really. I don't know that. To be honest with you, I don't know. It could be really easy case or difficult case, but CX is always difficult, right? So because it's CX itself is difficult, but this is young patients. We have a big landing zone. You know, I don't think it's that much difficult, to be honest with you. But again, because it's failed case, I thought that I may go easily subintimal space. So in that case, I would go RCA collateral. So let's see what we have after 2.530 balloon inflation. So these days we do lots of DCB for CTO as well. So if we have a good result, I hope we crossed it true to true. And let's see, down. So let's see if after 2.5, and then definitely we should go higher balloon before DCB. But if we have a good result, we will do definitely DCB because it's CTO. We will lose nothing, you know. Even we have occlusion, what we will have nothing. Okay, that's good. I like it. So let's do. I like it. Yes. This
So,
is good.
but you have more than 30% residual. So I don't leave.
No.
I don't leave this case by using just DCB.
No. Just let me work on it more because this is just 2.5. Yeah, 2.5 balloon. So let's do now trio. That's very good point. If I have residual stenosis more than 30%, for example, yeah, I don't want to leave it. Fully agree with you. But why I said I like it, it looks that I am true to true. That's why I said it's good. If I do DCB, I like to do 3.5 DCB here because it's huge CX. And if I put a stent here, because the patient is so young, I like to put here dynamic stent. I don't know if they call it bioadapter. I don't know if you have in Iran. That stent is after 6 months expandable with vessel, because link is resorbable. Yes. Links are resorbable, so after 6 months, links will be, all link will be free, and then metals can be expanded.
You mean elixir stent?
Yeah, exactly. Yeah. Do you have it in Iran?
No, it's coming.
Yeah.
I think very soon we will have it here.
Okay, guys. So I think it's time to think about it.
Yeah, you can. Of course, now you have both options because dissection is not fellow limiting.
Yeah.
Maybe it be reasonable to leave it with DCB, but personally I prefer putting a stent there.
3.5 alayım. Let me do another dilatation by 3.5. It will be the final appearance after DCB, right? Because if I do DCB, I will do 3.5 DCB. Let me do, and I will do long inflation a little bit. So,
okay, what do you think?
So
what do you think about doing IVUS and a scoring balloon after that?
But expansion is okay. Expansion, I think good, right? So it's
Yeah, but no, expansion is good,
You mean
but scoring balloon or cutting balloon helps you to delete the hematoma from
I see.
the wall, and so
I got it now.
yeah,
You think we
yeah.
have a big hematoma there? We have dissection, but I don't think we have a big hematoma, to be honest, because we didn't visit subintimal space. I think we have only dissection. Let's do so. Okay, so if I do DCB here, I would dilate here like 5 minutes, because when I see this kind of dissection, I do long inflation like we do peripheral. So let's leave it here a couple of minutes, and we can discuss something. So I think it's good option here. DCB, if we could, it's long disease, young patients, but if we could, let's try to do everything for DCB. If we think about stent, I can put. I like to put the dynamics if we have. So,
Omar, I had a question. How long do you put your DCBs in? 2 minutes or a little bit more? Because
very good
the
question.
peripheral guys always.
It depends. It depends, but I tell you, longer is better. That's for sure. You know, if you keep longer, you have better and better visualization. I mean, appearance. So if you have this kind of dissection, we definitely like to do 4 or 5 minutes for sure. But of course, this is not the issue. Not issue because we have collateral. But of course, if we work, if it is not CTO, then patient will have pain. In that case, we have to talk patient closely, explain that, okay, you will have pain now, that's fine, we are doing that. And then we ask him to please, stay calm, to have some time. So, and 4 minutes, 5 minutes is the best to have good result. I suggest everybody to do long balloon inflation, and I'll see lots of difference if I do only 1 minute or 90 seconds. Totally different appearance. In here, let's do a little bit longer. I don't think my nurse, as you see, he's just with patient. Explain him. That's the routine in our lab, and we do long inflation. Nurse goes to patient and talk to him, to observe him. How is the situation? So pressure is okay, and patient is good because it's CTO. Even it's LAD, non-CTO, we explain him, and then we have some 3-4 minutes, if we could. If not, of course, 30 seconds I think would be enough for any drug, I think. So I did this long inflation because I want to see the appearance after 3.5 DCB.
Hi dear Master Ömer. Can you hear me?
Yes.
Can you hear me? I am Mehdi. How are you?
Hi Mehdi,
Thank you
good,
for
good. How are you?
nice presentation. Thank you.
Nice to hear you, my friend.
I have a question. Why you don't want put a stent in this high grade dissection in here? It's not interfere with your other next procedure like CABG for patients, and you have a young patient. What's your reason for don't put a stent in such
basically because of
lesion?
basically because of the restenosis, right? So this patient has 41 years old. Imagine that if I put a stent, every year we have restenosis MACE event like 2%. Every year it's increasing, right? The MACE is increasing every year like this. So sometime later we might have issue with this after 10 years maybe, or 8 years, we can have issues with this stent. So every year, it's increased. I mean, every year we have some cumulative MACE. That's why, that's my main reason. Otherwise, it's not bypass area, that's true. But it's nice to put nothing, I mean.
Okay. And I see some suspicious component of thrombus and dissection in here. And do you have any document about DCB in thrombotic or ACS patients like this lesion?
You see the thrombus here?
I think that some thrombotic component plus dissection here.
I don't think so.
I suspect.
I mean, it's not easy to say, right? Or dissection always looks like a thrombus because appearance is like that. I don't think why we could have. How much ACT?
337.
So the first ACT we have 336.
Okay.
So it's quite
Thank you.
good. And
No, because of that dissection and thrombosis, it's neglected MI in some months before that procedure.
okay. So yeah,
Organized thrombosis.
yeah, but this patient has no recent MI that we know.
Microphone.
Yavaş yaşıyoruz.
Yavaş iniyoruz.
Start the call.
My question is there any evidence to support this decision making using drug eluting balloon in this case with CTO long segmental CTO with dissection or not?
Okay.
Did you hear the question, Ömer?
I hear, yes. So
Yeah.
they are asking the evidence, right? So
Yes.
they are asking the trial
Heparin.
studies.
Heparin var. 2000 yapalım heparin.
So I think we will have, I mean, we have now a registry. We will have in the EuroCTO club, we have, looks,
Oh.
you see that?
Perfect.
Yeah, that's what I mean. So
Heparin 2000.
let's try DCB here and 3.5
Sıfırlayalım.
40. And then after we don't want to do that much injection, right? Not to increase dissection. That's another rule. So in EuroCTO we have a big registration, and also we have our own series. I don't know. Let me ask Haşim how many we did so far. How many CTO?
We did around 100 CTO, maybe more than 100, and totally we did 400 cases.
All right. So yeah. So far we had in total like 400, but per patient, not per DCB. 400 patients, and 100 of them are DCB. So we are collecting our data, and soon we let you know the results of this DCB. So, but before having, registration, of course we will have and also randomization. We have a randomized trial from other lesions, but not CTO so far. But we will have soon. But it doesn't mean that we cannot do it. Some people has to do it. Some people have to do studies. Test. Slowly. Let's try. I think we have enough courage to do balloon dilatation here. Yeah, I'm using here essentials, right? This is iovascular essentials 3.540. Let's go 10, 12.
Opağı
12'ye
değişelim.
çıkalım.
12.
And then we tried not to occlude LED, of course. I think LED is okay. Okay, stay here. So we will stay another minutes. But I think you agree with me, if we do long inflation, the result is different. Bektaş. Let's see, I hope we'll do the same here.
Yes, I agree with you. Yeah. But regarding a specific brand, Sequent, please, they claim that 15 seconds is enough. But it's recommended to inflate between 30 to 60 seconds. But if patient becomes symptomatic, they claim that 50 seconds is enough because more than 90% of the drug will be released. And but lung inflation regarding to sealing the dissection, I think is better. Like in below the knee, that normally we inflate about 2 minutes to seal the dissections.
Excuse me. Good morning, Dr. Ömer.
Yeah.
I have a question. What's your threshold for stenting after dissection? I mean, do you put a stent in fellow-limiting dissection, or if in spiral dissection? When do you put a stent?
So that's a good question. So in this business, we are learning. Yeah, we teach ourselves and we teach each other. So if there is flow-limiting dissection, yes, we do stent. So no, not need to take any risk. for those patients. But if we have hematoma, if we have dissection, but flow is good, so especially in those cases we leave, and then we left lots of scary dissection, and we didn't have so far. I mean, Haşim is here, no acute occlusion. Interestingly, we are ready to come night, but there was nothing. So I think the risk of acute occlusion could be less, maybe less than stent. I don't know. So another thing, especially if we deal with the CTO, of course we have more courage because our vessel is already occluded. Even sometimes just we like to see, how it heals, because we need to see that. We have to see, we have to learn, which kind of dissection, what will happen. So if we deal with CTO, we have more generous to go with DCB because of low risk to have anything. So we have criteria, of course. If you have a type A and type B dissection, it's good to do DCB. If you have type C, it's recommended to put a stent. But most of the time, even some type C, we can go DCB. And for calcified lesion, I think DCB works very well because sometimes you have enough lumen, like 2.5 lumen, for example, for mid LAD. That's a good lumen for LAD, but you can't expand it. You have to do shock wave or you have to do something different. In that case, for example, DCB is very nice because you just dilate it. You don't put any stent, and then lumen is good, flow is good. So I think in many scenarios, DCB I think is good choice. That's why we use increased number all the time.
And I think a good point in this young patient is preserve vasoreactivity with the drug coating balloon despite drug eluting stents. And I have another good question. When you have dissection but with TIMI3, do you do follow-up angiography or CT angiography, for example, 3 or 6 months later to see the dissection is resolved or not?
So I saw your face now. You are Efsane, right?
Yes, yes.
I just saw your face. Sorry, I couldn't recognize your face, but yeah. So we do definitely control angiogram after 6 months. It's routine now because we want to see the result. We are doing DCB and we would like to see after 6 months. And most of the time we have, late lumen gain, not loss, but late lumen gain. So I think it's known thing now. We have even bigger gain after lumen after 6 months. So we do routinely follow-up for now. Of course, for a while, when we see after results and how much we have restenosis and how many of them we need to stent, we will have everything, and then based on we can maybe start to follow up our case by CT. But now we do CT coronary angio. Yavaş yavaş.
Hi. Do you use imaging before the coating balloon,
Do you want to see it?
such as IBUS study?
All right, very good question. If we do DCB, we don't use IVUS for sizing because IVUS shows us bigger lumen, right? Of course, 0.5 millimeter bigger. So if we do, if you like to do DCB, we don't use IVUS measurement. We use angio measurement because we have to stay a little bit conservative, not to have dissection, big dissection.
Ömer, in cases that you have crossed part of the CTO body via subintimal space, do you think that DCB would be useful or not for that part?
So, that's a good question. If you do knuckle wire, you know that you are in subintima, you do big knuckle wiring and everything, I don't think it will work. But if you try to wire it intraluminally, but some part you may go, subintima and intima, it could happen, right?
Yeah, but in case of, for example, a star case, okay, and ADR case.
No, I don't think it will work. No, no, I don't think so.
I think so.
I mean,
yeah.
there will be studies for sure. Let's see. I can't tell
Spider.
you that, Bektaş. So, I mean, in my logic, I don't know. It will be a little bit more difficult, right? I wish it could work, and then
Giriyorum.
all right. So we leave it like this, guys.
Excellent.
And
Very nice result.
yeah, I think so. So that side branch still feels from right coronary, but it will come back for sure. And now we will do right coronary DCB, because as I mentioned to you, I don't do that much injection. You know, it's better not to do much. So contrast of course dye may increase. But anyhow, the result is I think acceptable. So let's go to RCA. We can. Kaç yapalım abi üşümeyince? So we start to dilate by trio, and we will see.
Okay.
We will see. If I put a stent, that stent will be definitely trio, 3.5. But let's see what we have after trio dilatation. I don't want to big dissection here, of course. Let's see. And I have a fellow from Afghanistan, and he wants to say hello, Ahmet Cemal from Afghanistan. Kaç oldu bu? 3.30.
For such, Ömer, for such cases that we aim to leave it at the end by DCB, it's better to prepare the lesion by using lung balloons. It will give us a better result and more chance to end up the lesion with just DCB without a stent.
That's true. That's true. And that's why this is trio and the longest one we have. But I think you are right. We should have maybe longer for 40 as well. In some size we have 40, but trio we don't have.
Film.
You like? Yeah, you are right. Gir abi.
Very nice.
That's okay. We have some dissection at the distal which can be treated. Let's see. Let's see. Let's have a trio, not more 40, and then long inflation. And let's see. Maybe we can put a small stent later on. Let's have B Brown.
Ömer, you told us that you are so generous in using DCBs in CTO lesions. But I think, and I'm sure that you would be less generous in donor vessels. Yeah.
Yeah, yes, I mean, yes, of course. I mean, we always think about it. We always think the scenarios if we occlude it, if we have a, I agree with you. I mean, but we have a, I think, good experience. Let's see. Let's try DCB, long DCB inflation. If we don't like it, we can put a stent. Maybe we can put a short stent, right? So that's also advantage. The risk of risk and everything less. Huh? So, and here I will be also comfortable because now I will have collateral from CX to RCA. I don't think we will have that much pain here because we have already connection between two vessels. CX and this is B-Brown, guys. I like to cover this here. And then B-Brown is different than the other vessels. They expand a lot. We have to be very careful. But, for example, I tell you now, tell me, let's go for here for 8 only. Yeah, go up to 8. So, okay, 8. Go, stay on 8 and stay. Please, I like to have, I hope hematoma will not go down. Let's see. So 8, when we expand it is 8, it is 3.16. If we go 12, for example, by this balloon, 3.38. Right. If we go 12 atmosphere, this balloon reached 3.4. So when you use B-Brown, we have to be careful. Expand more than any other DCB. Balon koymamız gerekebilir. Okay, Haşim says that we don't. He says that he doesn't need. Yeah, he thinks we don't need stent, but let's see. So we don't have that much acute coronary syndrome in our hospital. In our hospital, we are reference hospital. We have some, of course, but not much. We don't have that much experience for acute coronary syndrome. We have less than 10 cases so far, and also we have used DCB in acute coronary syndrome. After balloon dilatation, if we like the result, we don't put stent. We just do DCB. So, Bektaş, how often do you use DCB in Iran? Is it now increasing or
Yes, it's
what's the
increasing, of
situation?
course. Yeah.
It's increasing, yes.
Yeah, true. Yeah.
Yeah.
There is a haziness in the middle of RCA with contrast staining. What's your idea about doing a hybrid strategy and putting a stent
Small
in that
stent.
part?
Exactly.
Yeah.
That's what I think. I mean, if I need it, I will put. I don't think that much. I mean, you know, it's not crime to put a stent, right? At the end, if we need it, we will put it. No worries. But it's like a kind of addiction, you know. If you do DCB, you always like to do DCB, right?
Yeah, sure.
So
yeah.
it's a different game. Nice to see bezel free of metal. 4 minutes 30 seconds. And slowly go down. When we deflate, we do it slowly. Ne diyorsun?
What do you think about the proximal part?
We didn't touch that one. We will do. We can do once more there, but I am thinking to distal. We can go a little bit more. I mean, this kind of dissection, we like to leave it. You know, we like to. We work a little bit more, and then we like to leave it. Okay. Let's do a little bit distal inflation. So I don't think the risk of thrombosis will increase that much. I don't think so. Even in my hand, I didn't see any thrombus. I don't know how much we crossed. You think how many we did hybrid? So far, we didn't have any of the experience that we have acute occlusion after doing paclitaxel and then laxer lumus or biolumus other lumus. We don't have any.
After 6 months,
Okay,
some
thanks.
restenosis, yes, but when we compare with the stent,
Yeah.
we lose it, and the restenosis rate is lower than stent.
Okay, so Haşim is very close to work on the DCB, and he all evaluate the results, and he said that the stenosis rate of so far we didn't publish it, but he of course do calculation himself, and he said the stenosis rate of DCB is less than the stenosis of stent.
Amazing.
Historically, yeah. He compare historically stent stenosis in our series, of course. I have also a friend just visit me, my hospital, who is from Russia. Okay, negative please. Let's do negative.
2,
6'ya kadar.
6,
8 yapabilirsin bunu.
8.
It's okay, yeah, there is air in the balloon. It's okay.
Yeah, it's a yeah.
Um,
Yeah, it's good. Yeah.
let me see. Empty please. Just empty. Sine, Flora. Okay, it's washed. So I leave it. Göster.
Geri.
I think I'm fine here. I leave it. I'm sure it will be healed. And you know, I don't know, maybe next year we will share with you the result of this patient. But I will leave it.
I agree with you.
Some of them
We can,
will not like.
can
I
leave
know.
it.
I know. But it's our routine. Let me do in our routine for this patient. So I'll leave it. Thank you very much for your attention. And
thank you so much. Thank
Yeah.
you so much indeed.
Yeah. Thank you.
thank you for your time and for everything, for your nice demonstration.